Welcome to this talk on digital epidemiology. My name is Ingemar. I'm one of the Deputy Directors of the EPSRC Digital Health Hub for AMR, which is the sponsor for this talk series. I'm also a Professor of Computer Science at UCL. Before I start, I should say that this is a very abridged and somewhat updated version of a tutorial I developed some time ago with Bill Lampos and Elad Yomtov. So hopefully at the end of this lecture you'll at least understand what digital epidemiology is, when it is useful, some examples, and what are some of the limitations of digital epidemiology. So of course epidemiology deals with the incidence, distribution and control of diseases and other health factors. But for digital epidemiology, it is epidemiology, but it uses data that was generated outside of the public health system, i.e. data that was not generated for the primary purpose of doing epidemiology. It goes by several other names, including computational epidemiology and infodemiology. And it brings together epidemiology and elements of computer science, including information retrieval, statistical natural language processing, machine learning, and human-computer interaction. So let's talk about data that was not generated for the primary purpose of doing epidemiology. What do we mean by that? So this is typically data that's often called digital trails. So people leave explicit and implicit evidence of their activities when they're online, but even when they're using other electronic services like mobile phones or using metro cards like Oyster, for example. Examples of explicit evidence are microblogs like Twitter, blogs, question and answer services, and social networking services in general. Examples of implicit evidence are web search logs and call data records. And if you're not familiar with these, for example, a web search log, so a search engine, when you perform a search, will record not just what you searched for, but the time of day, your IP address, which gives it an approximation of your location. It will also record what you clicked on in the retrieved set of data. And for call data records, similarly, mobile telephone operators record where your phone is and when you use it. Digital trails consist of a huge amount of data. So for example, Google has about 1 billion unique users a month and about 40,000 searches a second. Similarly, Facebook has 1.5 billion unique active users per month. And Twitter has approximately 300 million. So they're very large data sets. And this is a slide of the number of smartphones worldwide. And you can see that by 2021, we're at almost 4 billion, which is about half the number of people on Earth. Now, in many cases, the mobile phone network is quite advanced in low and middle income countries, despite the fact that the health infrastructure could be poor or absent. And so it's possible to perhaps use digital trails in these countries to support healthcare activities. So there are many data sources. We've talked about web search. There's general social media sources like Twitter, Facebook, Flickr. There's medical social media, so sites like Patients Like Me or 2 Diabetes. Medical internet aggregators like HealthMap. You can even use online advertisements in response to those advertisements to perform digital epidemiology. And there are other data from smartphones and fitness monitors. This is not a comprehensive list, but gives you some idea about the sources of data available. So let's talk about characteristics of these data sources. So one characteristic that you want from data is truthfulness. Are people providing real information? Sometimes they are, and sometimes they're not. And that is determined by the data and what's motivating people to produce that data. Anonymity sometimes helps to provide truthfulness, but also we need to think about the usefulness of the data as well. Sometimes when people are talking about cough and fever, etc., this might be just general interest in a disease as opposed to personal medical need. And sometimes we need to distinguish between the two. There's other cases where we may be seeing, on the one hand, real health concerns, and in the other case, imagined concerns, in that some time ago now, it's certainly improved currently, but when people searched for simple symptoms like cough, perhaps the first thing that was retrieved by a search engine was cancer. And this led to the concept of cyberchondria, this idea that you actually are suffering from a very rare disease because the search engine put that up in its top 10. So the data that you may be receiving also has metadata associated with it. So there could be demographic data, location data, medical diagnosis, etc. We've talked about implicit creation, and the other concern or characteristic of data sources is their accessibility for research. And that accessibility may change over time. So for example, Twitter, until it was purchased by and became X, had an academic API that allowed free download of a certain quantity of tweets per month. That accessibility is no longer available. Why do digital trails contain useful information for epidemiology? Well, they don't always, but here's a sort of anecdotal evidence of why some of them at least might. So this is a news article from 2019 in the Telegraph, and is quoting the Google Health Vice President. It's a little difficult to read here, but let me highlight a couple of points that are being made. So first of all, 7% of Google's daily searches are health-related, and that accounts to 70,000 health-related searches every minute. People are asking us about conditions, medications, symptoms, and insurance questions. And there was a study quite recently by Penn Medicine where they showed that health-related Google searches also appear to increase before emergency room patients visit a hospital. So that those patients are actually searching for their symptoms prior to going to the hospital. So now let me talk about why internet data may be advantageous for medical research. And there's a number of reasons why that may be. One is when it's harder to collect unbiased data in the physical world. Another is where more or complementary data is needed. A third is where the activity is largely web-driven. A fourth is where people have difficulty reporting associations. Latency can also be an issue. So how quickly can we get the data and make the estimates that are needed? And it's also potentially, we've demonstrated that it can be very useful at the start of a pandemic when conventional testing is limited or absent. So let me talk about each of those in turn. So when it's hard to collect a data set in the physical world, this is a graph of age of first-time sex. And the male and female graphs are done by a traditional survey from the Kinsey Institute. And the red line is from Yahoo Answers, which was a Q&A site that was active until about 2021. And here, people might post anonymously questions like, any tips for first-time sex at 15? And you can analyze that data to estimate the probability of first-time sex as a function of age. And that data, of course, is generally quite hard to collect in the physical world because it's a rather sensitive topic. Now, everything is not always that good. So conversely, here's a graph looking at the distribution of men's height in the US. And the one to the left, which is that men are shorter, is derived from the US Census Bureau, whereas the curve on the right is derived from a site called OkCupid, which is an online dating site. And there men appear to be taller. And presumably this is because the information they're giving is not accurate, and they're exaggerating their height under the assumption that women prefer taller men. So let me now talk about more or complementary data is needed. And there I think what I'm going to do is come back to that in a moment when I can go into that in more detail in an example shortly. Another reason to use this type of technique is when the activity is largely web-driven. And by that, I mean that in some cases, you've got patient websites like 2Diabetes that support patients with diabetes and their families. But also you have websites that actually promote dangerous health behaviors. So This is a site that promotes anorexia. If you look for information about measles, mumps and rubella vaccine, then of course the traditional media of television, newspapers, radio, it will not promote anti-vaccination rumours, but this is quite rampant on the web. Another reason to use this is when people have difficulty reporting associations. So I'm going to talk about an example of work done by Ilya Lyomtov and Evgeny Gabrilovich about adverse drug reactions. And these are reported by the FDA in America. So post-drug market surveillance is really depends on patients reporting symptoms. And it's hard to identify if an adverse reaction happens when the drug is taken over a long period. In other words, if that adverse reaction doesn't occur in the first week, but perhaps after the first or second month. And it's also hard to identify adverse reactions if several medications are being taken at the same time. In this paper, there was an effort to see if they could determine adverse drug relations based on web searches. So the idea here is to identify a set of people, of which initially they start with an anonymized set of 176 million users. They look for those users that are searching for a particular drug. They looked at the top 20 selling drugs in the US. When they start doing that search is when it's assumed that these people start taking the drug. And then they look from that point on about whether they look for symptoms that might suggest an adverse drug reaction. There's a lot of detail to doing that. What they discovered was that in fact they could see the adverse drug reactions reported at the FDA site, but they also discovered some potentially other adverse drug reactions which had the characteristic that these drug reactions occurred later and were much less acute. Another advantage is when latency is an issue, and so here's an illustration of a bit of work we did recently where we're interested in estimating antimicrobial usage. So you can find ground truth data for this in the English prescribing data database, and we could collect that from, say, January 24 to January 23. Now this data is updated periodically, but probably less frequently than every month. So there's a latency of at least a month involved. Now, we took 328 unique queries and their frequencies over that same period and used elastic net regression, a simple form of machine learning, to develop a model to estimate the antimicrobial usage each week. And this is the sort of data that we get. And you can see that the estimate and the ground truth data from English prescribing data are very, very similar. But here the latency is being reduced to 1 day from 1 month. It's also potentially useful at the start of a pandemic when testing is limited. This is work led by Bill Lampos as part of the work we did for COVID-19 and user search queries. Here it uses an unsupervised learning method where we used weights derived from the NHS first few hundred symptoms for COVID, such as loss of smell, and developed a model for that. Later, Bill applied transfer learning to transfer those models to other countries. And it was very useful, particularly in the early stages of the pandemic, to verify that lockdowns were actually reducing the prevalence of the disease. So let me continue with a few other examples of digital epidemiology. Before I do so, though, let me start with a paper from 1977. So the point of this is that ideas about using this kind of data date back quite some time, at least to this paper by Well-Liver and others, where they were looking at volumes of sales of over-the-counter cold remedies as a way to estimate the prevalence of influenza in the population. In the early 2000s, so about 2001, Wagner and colleagues showed that web searches from a specific website, WebMD, could be used to estimate prevalence of diseases. And then there was a series of papers beginning in 2006 and culminating in 2009, where it was demonstrated that you could detect influenza and other diseases and their prevalence based on web search data. So I'll continue with the examples by just a few that we've done over the past few years to do with mass gatherings, personal health HIV, and vaccinations. These were all in collaboration with Microsoft Research. So in mass gatherings, such as large sports events like the Olympics or religious events like the Hajj, or even music festivals, you have the risk of infectious disease. And it's quite hard to monitor this because you've got a lot of people coming in very quickly. The event may only last a few days, and then they disperse geographically, perhaps not just nationally but internationally, and it's quite difficult to continue to monitor people. So we looked at whether we could do this using Twitter and search logs for surveillance. The general idea is that if you tweet or search for a particular event, say festival, if you tweet it or search about it enough times, then we make the assumption that you're actually attending. And then if you're attending, we look at your tweets before, during and after, and then look to see whether there's any statistical changes in the symptoms that you're reporting during those 3 periods. And you can see that in these results that we could actually detect changes in symptoms such as cough, tiredness and depression. Another project that we did in collaboration with Public Health England was to look at whether we could measure the effectiveness of a public health intervention. And in particular, Public Health England in 2013-14 introduced a children's vaccination program for influenza. The idea here wasn't just to protect the children, it was also to protect the general population, even if they were not vaccinated. And the idea being that children are a spreader of the disease, and the fewer the children that have influenza, the fewer other people will get it as well. So they did this study on several pilot regions, and it was a relatively mild flu season, and they did not get sufficient data to be statistically certain of the outcome. We looked at this data where the country's broken into pilot regions and control regions, where we built models to estimate the prevalence in the pilot regions. We built models to estimate the prevalence in the control regions and use the control regions to estimate the prevalence in the pilot regions if the pilot regions had not been vaccinated. And we could look at that difference to show if there was any effectiveness. And our results confirm Public Health England's initial assessment. Those 2 examples are looking at population health, but you can also use this data for the health of the individual. So of course, online behaviour is usually not a cause for a health event. However, online behaviour is often a proxy for physical behaviour. So for example, if you're searching for climbing equipment, that's probably an indicator that you're climbing, and that's likely to be indicative that you're at higher risk of injury. This work dates back to at least to 2012, I think, when there was a news article about the Target department store, which started sending a young woman information about products to do with pregnancy. Her father was extremely angry about this and complained to Target, only to find that Target's analysis of her queries to the Target website had indeed correctly determined that she was pregnant. So in 2015, quite some time ago now, we looked at automatic identification of web-based risk markers for health events. We did this for a series of conditions, including pregnancy, allergy, HIV, and eating disorders. How did we know people were sick? Well, we relied on what's called experiential queries, because we had no contact with the users, and of course they were anonymous to us. But users actually tell the search engine using queries like, I have HIV, I've just been diagnosed with HIV, I'm suffering from HIV. And we use those types of queries, experiential queries, to infer that this is the time of the diagnosis. And we then go back and look at the previous queries that these people made to see if we could have predicted this event. And we've done this for a number of them. Pregnancies, I think the precursor behaviours are rather obvious. Allergies are somewhat strange. Searching for Petco, which is a pet food store, or pet stores in general, was a precursor behaviour to allergies, and quite likely due to the fact that people had just purchased a pet and subsequently found that they were allergic to it. So since that time, though, there's been a number of other works that have shown that you can do this again using experiential queries for pancreatic cancer, for lung cancer, for ovarian and cervical cancers, and also for diabetes. We've also talked about the fact that web search queries change just before going to an emergency department. And most recently, we conducted research where we replaced the experiential query diagnosis, which is not certain, by a clinical diagnosis, where we recruited a cohort of women who attended a gynecological clinic. And this paper again shows that looking at their search histories, which we acquired through the support of the women and their use of Google Gmail and Google Takeout to get their search histories, we're able to show that we could have predicted that women would go to these clinics up to a year before they actually did. So I haven't spoken very much about the underlying technologies behind these research studies. There's a lot of work that goes on in statistical natural language processing, particularly to do with disambiguation of phrases. So we're interested in phrases about "I have fever," but we're not interested in the movie Saturday Night Fever or Bieber fever. We use natural language processing to acquire demographics and also to do generalization. So if there's a query for augmentin, we can assign that to a category antibiotic. And we can use something called word embeddings to allow us to determine synonyms between medical symptoms and what people use casually on the web. Underlying technologies also include machine learning for feature selection and linear and nonlinear learning processes, from simple regression through to Gaussian processes and neural networks. So now let me talk about the limitations of using this kind of data. So user-generated data can be biased. We talked about that with OkCupid as an example, but also very young and very old people are underrepresented on social media. Not all social classes are covered, and people that post content about a topic may also be a biased subset with characteristics that are difficult to specify. Data collection, formation, extraction can be problematic. Access can be very limited. In many of the studies that I've described here, we had anonymized access to individual searches where that access was only within the corporation that was performing the web searches. Filtering for location data, etc., can also be difficult. And in many cases, you're only getting a sample of the data, and it's not. Sometimes that sampling is opaque as to what exactly it's doing. Finally, we've talked about how large these data sets are, but they're not very long. And by long, I mean the time span of the data can typically just be a few years, when we may want that time span to be decades. And for digital data, that's quite rare, particularly because in many cases, companies either by choice or obligation delete the data after a short period of time. There's also obviously concerns about privacy and ethics. The figure to the right is about a study that was performed at Facebook, where they took a cohort of Facebook users and split them into two groups and then showed them different content and demonstrated that the two groups' emotions were changed. And the controversy there was that this cohort was not aware that they were part of a study and there was no informed consent. There's also regulatory issues that we have to consider, like the General Data Protection Regulation Act of the EU, which is a lecture in itself. And there's also other legal issues, particularly when it comes to cloud computing and jurisdiction. So if you're using Amazon Web Services, it may not be that the data no longer resides in the UK, but could be almost anywhere in the world. So let me finish here with some further reading, of which there's many, and just make a few acknowledgements. Once again, the funding for these talks is from the EPSRC Digital Health Hubs grant. And as I said at the beginning, this talk was based on an earlier tutorial that was jointly developed by Bill Lampos and Elad Yom-Tov. And finally, here's a partial list of collaborators who I'm grateful for all of their help that they've given me. Thank you.